Thank you, Chairman. Good morning, everyone. I'm a cardiovascular surgeon at our center. Carotid Endarterectomy is performed by cardiothoracic surgeons. Now I would like to present a surgical perspective on the treatment of carotid artery stenosis. I have no disclosure. This chart demonstrates that prevalence of carotid stenosis increases with age and is higher in men. Given the substantial nationwide burden of ischemic stroke, many of these patients may become candidates for carotid endarterectomy (CA) or carotid artery stenting (CAAS). Carotid endarterectomy has a long history. The first CA was performed by Dr. DeBakey in 1953, and the first published case was by the East Coast in 1954. These pioneering efforts demonstrate that surgically removing plaque from the carotid artery could prevent stroke, while CA was performed for decades, its efficacy was conclusively demonstrated only in the late 20th century through major clinical trials, previous speaker showing. The basic carotid endarterectomy is incision for the neck to expose the carotid artery, clamping the arteries, branches, and opening it to remove the atherosclerotic plaque. After removing the plaque, the artery is typically closed with a patch angioplasty to widening the lumen and reduce risk of narrowing. Direct closure can be performed, but it is associated with higher risk of the restenosis. So carotid endarterectomy effectively removes atherosclerotic plaque with a low risk of emboli ischemia because of clamping distal branches. Previous speakers showing the guidelines for the treating coronary stenosis. I want to speak the I want to speak the more detailed the guideline by this diagram. So my major population is divided into the symptomatic and asymptomatic patients because this is very different prognosis. So symptomatic patients with significant stenosis is highly recommended to the carotid endarterectomy and best medical therapy is class 1A because there is a high risk for the future events. Moderate or less than 50% is individually accessed, and asymptomatic patient is best option is best medical therapy because asymptomatic patient's prognosis is benign. So yearly incidence is only 1%. So intervention efficacy is not well evaluated in this cohort. But previous speakers showing the high risk patients can be with the significant carotid stenosis can be deal with the carotid endarterectomy plus best medical therapy can be done. Guideline for treating coronary symptom is a European Heart Journal is 2024 published. This is by the multidisciplinary team. Regarding intervention, guideline constantly recommend carotid endarterectomy for symptomatic carotid stenosis more higher than 70%, provided the surgical risk is acceptable. Carotid stenting is generally reserved for the certain situation, patients at high surgical risk or with unfavorable anatomy for surgery. Notably, this guideline showed the TCA, transcarotid artery calcification, was shown. I will discuss TCA in detail later, but keep in mind that guidelines are evolving as a new evidence emerges. This graph illustrates, this graph is retrieved from the National Health Insurance Service data. Current Korea Korea carotid procedure was summarized in this graphics. In many countries, the total number of carotid procedures performed annually has been increasing. The left panel shows the annual number of carotid surgery. Is over the 14 years, surgical cases is stationary, and some of the cases only the 700 cases. But the percutaneous intervention, including the vertebral artery intervention, the strikingly higher prevalence in the over the years. So some of this procedure more than near the 5,000 cases is performed in the Korea. It is worth noting that this trend can differ by the region. For instance, in South Korea and some other countries, carotid stenting is performed earlier and widely used compared to the other countries, especially compared to the United States. This analysis from the U.S. Vascular Quality Initiative database exam trend from the 2015-2019. Over the 5 years period, total volume of carotid information increased significantly. This digital is I think is long, so more carotid intervention is more than 15,000, and to increase it to the 27,000 cases. And but the major stream is done by the carotid endarterectomy. But the at the 2019, transcarotid artery revascularization was performed highly proportions. So very rapidly, coronary intervention is replaced by the TCAR. This data is symptom. Let me see why carotid endarterectomy becomes standard care in the first of choice. In symptomatic patients, those who have had transient ischemic attack or minor stroke from the carotid stenosis, CEA was proven beneficial by landmark trial, the NASCET, published in 1991 in NEJM. CEA group showed the reduced stroke and composite with death compared to the medical therapy group. By performing CEA in epileptic symptom patients, we are often preventing what could be disable or fatal stroke. Therefore, current guidelines strongly recommend carotid endarterectomy for symptomatic carotid stenosis greater than 70%, provided that the perioperative surgical risk is acceptably low. For asymptomatic patients, benefit of intervention is less obvious because their natural risk stroke is lower. ASCA enrolled patients with 60% higher stenosis and no symptom randomized to CA plus medical therapy versus medical therapy alone. 5 years results show the 53 relative risk reduction in stroke with surgery. This is why currently guideline only advise considering CA for asymptomatic carotid stenosis if patient's life is substantial and the surgeon's perioperative stroke death rate is reliably low. This CREST study is introduced previous speakers, so I don't want to see this now. So many studies shown that the long-term result of carotid artery stenting and the carotid artery endarterectomy is similar, but most trend is very favorable to carotid endarterectomy, but the statistic significance is low. One major advance in surgery has been routine use of a patch to close the arteriotomy. Rather than simple suturing the arterial close, patch widening the closure is a very good technique to the preventing the stenosis. Alternatively, eversion CEA avoid patches may reduce stenosis come from the patch events. Everest trial showed the non-inferior to conventional CEA in stroke of the everting endarterectomy technique. Stenosis is lower in the everting endarterectomy. It requires greater technique skill suitable for certain anatomy due to the large incision. The choice of often depends on the surgeon preference and the patient's anatomy. Advancing in anesthesia monitoring has significantly contributed to improvement of CA outcomes. During the carotid endarterectomy, protecting brain from ischemia is important while the artery is clamped. Several monitor technology help us ensure the brain is adequately perfused. Monitoring with electroencephalography, somatosensory evoked potential, near-infrared spectrograph detect ischemia during clamp, allow timely shunting to protect the brain. Easy monitor use under general anesthesia can detect change in cortical electric activity that suggests ischemia in area supplied by the carotid artery. SSEP also reflects brain ischemia. NIRS or cerebral oximetry is a non-invasive monitor that estimates regional cerebral oximetry saturation. A significant drop indicates reduced cerebral blood flow in that area. In this case, carotid artery clamp induced change in the EEG and the SSEP signal, such as decreased amplitude or delayed latency. Following shunt insertion, activity was restored. This demonstrates that cerebral ischemia during carotid surgery can be sensitively detected by multimodal neuromonitoring, allow timely intervention to prevent neurological injury. NIRS has gained popularity due to its easy of application, although it primarily reflects frontal cortical oxygenation. As shown in this right panel, sequential clamping of the carotid artery leads a measurable decrease in regional cerebral oxygen saturation. When you face this cerebral perfusion is decreased when we clamping the carotid artery, we can do the shunting with this device, the balloon catheter. This shunting technique keep the brain perfusion during our surgery. There is a debating issue regarding shunting use. Some surgeons advocate routine shunting. They place a shunt in every CA cases. The advantage is all patients receive continuous cerebral perfusion, so the surgeon doesn't have to worry about monitoring or ischemic time. However, routine shunts have some drawbacks. Inserting a shunt can itself cause arterial wall damage or dislodge plaque, and it adds complexity because a very large cannula is placed on the surgical field. On the other hand, selective shunting means you only use the shunt if there are signs that the brain is not tolerate the clamp. For example, if the EEG show loss, the selective cerebral shunting is used during the surgery. Selective shunting avoids unnecessary shunt placement in the majority of patients for reducing risk of the shunting-related complications. During surgery, meticulous anesthesia management is essential. Mean arterial blood pressure should be maintained above 19 mmHg during carotid clamp. After revascularization, increased flow to the dilated carotid artery may lead cerebral hyperperfusion. Medication that reduce cerebral oxygen consumption can be helpful in mitigating ischemic injury during the surgery. Typically, patients are monitored in an ICU for the first 12 or 24 hours. Frequent neurologic check, for example, every hour for the first 4 or 6 hours. Don't catch any early sign of stroke or hyperperfusion syndrome. Blood pressure is tightly controlled. We want to avoid hypotension, which could compromise the carotid plaque removal site or the cause watershed cerebral ischemia, and avoid severe hypertension, which can precipitate reperfusion injury in the brain or cause the surgical site bleeding. A neck hematoma can be dangerous because if it expanded, it can compress the trachea and larynx, leading to airway obstruction. Transcarotid artery revascularization is the most important recent technology advances. TCAR is essential for hybrid approaches with surgery and stenting. In TCAE, a surgeon makes a small incision at the lower neck to expose common carotid artery and then directly insert special stress into the carotid. The hallmark of TCAR is a neuroprotection mechanism. Before deploying the stent, the system establishes temporary flow reversal in carotid artery. It's shown that small incision to compare to the conventional CEA, this shunting is placed from the carotid artery to the femoral vein. When we are deploying the stent, the proximal common carotid artery clamped, and the reversal flow is from the carotid artery to the femoral vein. All the debris during the stent is filtered in this site. TCA has gained enthusiasm is its strong clinical outcome in studies so far. In VQI registry analysis, TICA outcome are promising. Stroke rate is 1-2% comparable to the CA, but there is very low compared to the transfemoral carotid artery stenting. In terms of stroke and death, TCAR showed preferred compared to the transfemoral carotid artery stenting. So this is adjusted stroke and death rate were significantly lower compared to the transfemoral carotid artery stenting. As previously shown, TCAR had rapidly replaced both carotid endarterectomy and transfemoral carotid stenting in the United States. In conclusion, carotid endarterectomy has seen significant technology and procedure advancements that have enhanced its safety and efficacy, from patch angioplasty and eversion technique to sophisticated neuromonitoring and selective shunting protocols. This improvement resulted in low perioperative stroke rate with CEA. The newest hybrid innovation, TCAR, offering surgical level stroke protection with endovascular minimal invasiveness, and has rapidly become a prominent option for high-risk patients. Crucially, whatever modality is chosen, it should be in the multidisciplinary team with the individual patient's anatomy, comorbidity, and preference. Thank you for attention.